talking, I think for the first time, about sharing a kind of collective responsibility for health in order to improve the economy, improve productivity, and make better lives for all of us.
That's my Treasury-facing argument. Healthy economy is built on the bedrock of a healthy society.
Thank you.
We'll see how far we get with that.
Well, I think we buy it. OK, I'm going to move to the first question. There's quite a competition going on my iPad here at the moment. So this one says, Monday will mark my 33 years as a GP, not mine, somebody out there. And in that time, this person's got a long memory. There have been 18 health secretaries, and they've nearly all promised to focus on primary care and prevention. Can you guarantee that the rise in number of NHS GPs will at least match the rise in the number of consultants? And I think this is referring to the long-term workforce plan, where the modelling is appearing to show that there'll be a rise of 4% of GPs by the mid-2030s and a 49% rise in hospital consultants in that same time period. And that seems a bit crazy if we're trying to marry that up to your three themes.
Well, I thought there was lots in the Darcy diagnosis that was not a surprise to me, even if set out in black and white against a whole load of other factors. It is a shocking picture. But one of the things that was a real shock to me was the extent to which resources and staffing in hospitals has increased since 2019, but productivity has fallen. And it is kind of grist to the mill of the argument I've been making in opposition that the source of the solution to the crisis in the hospitals actually lies outside in primary, community, mental health, social care, diagnostics, which does not have to be, and I would argue should not be, primarily a secondary care activity. We should be doing much more diagnostics out of the hospital. And it goes to the fundamental argument I've made, particularly in response to any number of columnists in some of our centre-right and right-wing newspapers about the model of the NHS and why other countries' funding systems are better. Our outcomes are nothing to do with the model of funding, but it is about where the funding goes. You know, we run hot on hospitals, but we run either near the bottom, at the bottom, or even seriously lagging behind on primary care, community services, mental health, social care and diagnostics. And if we don't shift not just the centre of gravity, but also where the resources go, we will continue to spend quite a lot of money on pretty poor, relatively speaking, outcomes. So we do need to deliver that shift. I'm really serious about it. And in that light, although previously we've said we wanted to maintain the long-term workforce plan, we wanted to give the NHS that certainty, and for the moment it remains business as usual. As part of the 10-year planning process, I think we will have to revisit some of those core assumptions in the long-term workforce plan, because I think you are right to draw that contrast in terms of size of growth in hospitals versus size of growth in primary care, not least given the Darcy diagnosis. So I think the Darcy diagnosis necessarily leads us to a different prescription on the long-term workforce plan.
Thank you, because if you really want to achieve what you're setting out to achieve, you're going to need plenty of us. And at the moment, it doesn't look as if there will be plenty of us. So we really need to do something about it.
I'd also be surprised if in the future we don't see, more horizontal integration and working as well across primary and secondary care. And I think it'd be great if, 10, 20 years down the line, we've kind of started to break down that almost artificial divide between primary and secondary care and think more about teams of staff and groups of patients and having more integration across patient pathways. I think there's a lot for secondary care to learn from primary care, and a lot that goes the other way around as well.
And to some extent it's happening already, isn't it, in some places, I know. OK, so my next question then is about the Darcy report, in which you say he's just a surgeon, but he did say that he applauded the partnership model of general practice for innovation, productivity and fiscal responsibility and cost effectiveness, really. What is your opinion of the partnership model and support for the partnership model?
Well, people may remember I kind of deliberately, this is what happens when my comms advisor goes on holiday, I decided in an interview with Rachel Sylvester in The Times that I would kick the hornet's nest on the partnership model and deliberately, and it was a deliberate provocation, deliberately provoke a debate about reform. And there was some real and kind of beyond, wanting to have a proper debate and to sort of shake the system into a discussion about reform. There were some, I think, underlying serious and substantial concerns I had about the partnership model. Particularly the decline of the partnership model, and my view at the time was you either need to grip it and say this is important to the future, or you need to accept that it's on its way out and think about what comes through to replace it. And where we've been as a country for quite a while now is the status quo, which is sort of withering on the vine and sort of mismanaged decline. And so I kind of entered into that kind of row with a deliberate provocation, but also, as I said right at the very outset, a genuine willingness to have that debate. And I know this is kind of a novel approach in politics, to do genuine consultation and to listen to what people say in response to arguments. But that's exactly what we did. And, I've definitely seen over the last few years the real benefits of the partnership model, the innovation that it inspires, a sense of entrepreneurialism, efficiency, productivity, and going the extra mile for patients, because people are literally invested in their practice, as well as invested emotionally and ethically in their patients, which I think is a common experience across general practice, whatever model you're working in and whatever your contractual conditions you're operating under. And so the question then, I think, for me, has not become about the model of general practice, but more about activity, funding, and what a future partnership looks like. And I know this is where kind of our CGP is well, what would a new model partnership look like? And how do we sort of arrest the decline and recognise that the mixed economy we have today in general practice is one that we're likely to see into the future, but we should manage that in a more strategic way than has been the case. So that's kind of exactly where we are. And it's the reason why I didn't talk about the partnership model in the speech, because I just don't think it's a first-order concern at all.
Mm. Well, we're not ready yet, but we would very much like to work with you on that, because we need to save the best of the 20th century partnership model for the 21st century partnership model. And
I really understand the barriers to participating in it.
Okay, so I want to move on then to my next question, which is that we know now that just over half of all our GP registrars have trained abroad. They're international medical graduates. And the visa rules mean that many GPs training in the UK struggle or worry about struggling to remain in the country after they finish their training, because they need another 2 years of visa extension. Other countries, such as Australia, who are very anxious to take our trainees because they're so good, are offering indefinite leave to remain at the point of completion of training. Why can't we do the same?
So there's two... I think there's two parts to that challenge. One is the challenge of other countries nicking our people. And, short of running a TikTok and Instagram black ops operation against Australia showing large spiders and snakes, and whether that isn't as good as you expect it to be, we probably need to do much more substantially on retention and career progression to give people some hope and confidence that there is a bright future for their careers in this country. And then more generally, the debate about the contribution of overseas recruits to the NHS and social care system is a nuanced one. And this is a country at the moment that doesn't deal very well with nuance. But two things can be true simultaneously. Firstly, we are very lucky, and have been for 76 years, that there are people from around the world who come to this country and choose to dedicate their skills, their expertise, their care and compassion to serving patients and caring for people, whether in the NHS or in social care. and the system would fall over today without those international recruits. We're lucky to have them. Later today, when I'm going to Alder Hey, I will be meeting some of the people who dealt with the most unimaginable horror of the Southport attacks. Last week, I was at Southport Hospital meeting a team of clinicians and staff who have been part of the same response in Southport itself. And beyond the undescribable and also awe-inspiring recollections they offered about the way in which they swung into action and pulled together as a team, the thing I found most blood-boiling is that the very people who rushed into that situation to save the lives of others in the most appalling conditions were also people who the very next day and in the subsequent weeks were victims of racism and racist riots on our streets. And so I think it is important in this context, and I was really proud of the speech the Prime Minister gave in Liverpool, our conference last week, to be unequivocal in our condemnation of racism in our society and to make it clear that people who come to this country to contribute to not just the NHS and social care, but people who over generations have built the country we see today, we should actively celebrate that, and I think all of us have a responsibility to stand up and condemn the racism and the extremism that we see unchecked and in some cases actively fanned by people who should know better. And that's an important message for me to send. And I think people would also recognise that this is a country that has become over-reliant on overseas recruitment in health and social care for a number of reasons. Partly it's Treasury brain that says, actually, we don't need to train our own people, that's quite expensive, we'll just recruit from overseas, which is incredibly short-sighted. It assumes that global talent pool will always be there to draw on, which against a global shortage of health and care workers is a strategic risk. It assumes that it's morally acceptable to continue to recruit from red list countries who have severe shortages of their own workers, and I think that is unethical. And it also says to people in our own country who might want a career in health and social care, either we're not prepared to invest in your training and your opportunities, or in the case of social care in particular, we're not prepared to pay the wages that reflect the professional job that you do in very difficult circumstances. And so I think it's part of my job as the Health and Social Care Secretary to help the Home Secretary to reduce net migration, to reduce our reliance on people from overseas, even at the same time as we recognise that they do and will continue to play an important role in our health and care, and this will always be a system that has an international dimension to it. And that is a good thing in and of itself. I think it is a good thing that we have people coming from around the world with different perspectives, skills and experiences to contribute to our practice here in the country. So it's a nuanced position, but this is a country that needs to deal a lot better with nuance, and so we will continue to take a nuanced approach to immigration. And the shorter answer to your direct question, what about the visa route? Immigration policy is a matter with the Home Secretary, but I've heard what you've had to say very carefully, and there is some merit in the argument you're making.
Okay. So it does feature in our manifesto asks, one of our 7 asks as a college, so we will carry on lobbying you and the Home Secretary and anybody else that needs to be. So do direct us in the right directions if you feel our voice might be listened to. Okay, I think we have time for probably one more question. And this one has got quite a lot of people asking. The last government stopped funding for new-to-practice GP fellowships, which help newly qualified GPs in the early part of their career. Will you restart it?
Yeah, it's something we're looking at. I mean, obviously, there are lots of things we would like to do, and the kind of really boring answer is subject to budget and spending review and pressures, but I recognise the value of the fellowship and that early career support and professional development, and I think it also speaks to the signals that we're sending to people early in their careers about whether they've got a future to look forward to in general practice in this country. And that's why, I mean, as I say, I know it's not a panacea, but an early down payment on GPRs I hoped wasn't just about practical solutions, put people into jobs who otherwise wouldn't have them, and in front of patients who otherwise wouldn't be able to see them. It was also about saying, you know, we recognise your value and we want to make sure you've got a bright career and future to look forward to in the NHS.
Thank you very much, Wes. I've actually got 3 minutes. I'm going to ask one more. Hope you don't mind that. So this one is about estates, and it's really that you know, we know that we're planning to increase numbers of GPs, but what about the crisis in estates in primary care? If we're going to be training double the number of medical students, 50% more GP trainees, and an awful lot of other allied healthcare professionals, and we don't have the room to do it in. And many of us are working in crumbling. I've spent years working out of a porter cabin, for example. You know, what plans have you got there?
Yes, as I said earlier, I can't correct 14 years of underinvestment in capital in a single budget or a single spending review. But what the Chancellor and I do want to do is firstly break the vicious cycle that we've seen where the explosion of day-to-day deficits across the NHS mean that we raid capital and tech budgets to plug the shortfall, because we effectively raid tomorrow to plug deficits today, and then perversely day-to-day cost pressures become harder to manage because we haven't invested in the capital and the tech infrastructure that will enable people to be more effective and more productive, so the costs continue to spiral. And so we are thinking very carefully around the spending review and beyond. How do we prioritise tech and capital investment in areas that will help us to bring those day-to-day pressures back under control and put the NHS onto a more sustainable footing so we can turn that vicious cycle into a virtuous circle. That's not going to be easy and it will take time. It's also why I've had to put my foot down a bit with a degree of political risk and pressure involved to say that the debate about capital in the future of the NHS is not simply about new hospitals. In fact, when I look across the NHS estate, yes, there are some very visible problems in our hospitals, including one of my own local hospitals. But there are also real issues in the primary care estate and the mental health estate, which do not get nearly as much oxygen, spotlight, or media headlines. And so when we're thinking about choices and trade-offs and priorities, we are having to do that within the NHS's capital programme as well. And it's why I've had to kind of grip the new hospitals programme. I mean, it's not just that the timetables were works of fiction and the money for the programme ran out, or it's due to run out this March, which is a mild problem. It was also that, okay, as I'm thinking about then timetables and phasing and capital allocation, I've also got to balance those priorities against other pressures. And those are just the capital pressures in the NHS. You could have the Education Secretary on this panel and she would talk about the education estate. You could have the Transport Secretary on this platform talking about transport infrastructure. The Energy Secretary is in Liverpool today with the Chancellor and the Prime Minister. The Science Secretary could talk about data infrastructure. This is a challenge right across the public sector, and it's why this debate and discussion about choices and trade-offs is a really important one, and why these are difficult issues, but this is what we signed up for. There's one thing that I hope will give you some confidence about this government and the way that it approaches these sorts of questions. Around this time last week, we were in this city with the Prime Minister giving a speech to the country that, yes, was full of hope and vision, but also confronted people with choices and trade-offs, whether about housing or prisons or pylons. We can't pretend that there are easy answers. I mean, that's where the populists call us to, the sirens on the rocks, and there's no future for the country in that kind of short-termism, sticking plaster politics, government by gimmick. We've got to face up to hard choices, and we will do that, and we will also do it in a values-driven way, and we will try and take the country with us. This is going to be quite a test for us, whether or not opinion polls will follow the kind of straight-talking leadership that people say they want. Let's see if it actually works in practice. But I think we can all agree we've had enough of short-termism, we've had enough of sticking plaster politics, and we've had enough of government by gimmick. And that's why moments like this are really important, because it's an opportunity not just to come and talk, but an opportunity to listen. This is not the end of the conversation this morning, it's just the very beginning of the conversation, and crucially, it's the start of building a real team spirit where we face up to these difficult choices and trade-offs together, where we explain our thinking, you're able to challenge it, inform it and shape it, and where we build the future that we want to see for the NHS together, which I still believe, in a triumph of hope over cynicism, is absolutely there for the taking if we make the right long-term decisions now, which we are determined to do.
Thank you so much. So, I'd like to thank you for your time and your candour. I'd like to thank you for opening up to us your thinking. It is so refreshing to hear a government that is looking forward, many years forward, perhaps in the way even as Anna and Bevan did 70 plus years ago, and you're not thinking short term, and that is just very refreshing. And we look forward to having you back then next year, as you have promised.
Yep.
Yeah, thank you.
Definitely.
And I also wanted to thank Reshma, Paula, Sinena and Andy. Thank you so much for coming to tell us of the work you're doing. And please write to me, because I'd quite like to talk about you in my email blogs out to members so that we can spread the word even further than this hall. And thank you very much, everybody.
Thank you.
See you all soon.
Thank you. Thanks very much. It was really good.